Hey there, this is volume 2 of Emergency Pediatric and Neonatal Care. We're going to discuss a few questions in this recording. The first one being, what is the appropriate ventilation rate when resuscitating an infant? Now, pay close attention to what it's asking. We have people miss these questions on the wall because they are in a hurry, and it's asking you for ventilation rate, not compression rate, okay? It's easy to get in a rush. You have 3 hours to take these tests, so just try to go a little slower and don't get tripped up on vocabulary that you just assume what they're asking. So be super careful, watch your key words. So the appropriate ventilation rate for resuscitating an infant is 40 to 60 per minute. It gives us some other options of 20 to 40, 60 to 80, 80 to 100. We know that the 20 to 40 would be too slow, and 60 to 80 or 80 to 100 would definitely be too fast, and they would go into some type of hyperventilation. Their PCO2 would be too low on the blood gas, and we'd throw the pH all off. So let's stick with right there in the middle of 40 to 60 is a good ventilation rate for resuscitating the infant. The next question we're going to discuss, what location do we use to assess the pulse of an infant? We don't use the radial artery like we might with the adult. It gives us these options. Do we use A, brachial artery, B, radial artery, C, carotid artery, or D, temporal artery? We know that we use A, the brachial artery, or you can take your stethoscope and listen apically over the slightly left of the thorax of the mediastinum and listen that way. But if you're using the tips of your fingers to assess the pulse, let's do that over the brachial artery in the infant. The next question, what is the rate of compressions to ventilation when performing 2 rescuer CPR for a 6-year-old child? We are going to look at the options. 5 to 1, we know that would be too low. 15 to 2, too low. C is 30 to 2, which is baby bear soup just right. So D is 30 to 4. We wouldn't want to take that long to stop compressions. So we would do 30 compressions to 2 ventilations. And then just continue that until you get a heart rate on the monitor, or can feel a heart rate by checking the brachial artery, remember. Okay, the next question, 20 minutes into a resuscitation of a premature newborn, ventilations, compressions, and IV access have all been established. Blood gases are obtained and are as follows. The pH is 7.20. We know that's acidotic. The PCO2 is 39. It's just a little bit, 40 would be normal, so we're okay there. PO2 is 65. Bicarb is 16. Based on these findings, the neonatal pediatric specialist should recommend A, do we need to hyperventilate? No, we are perfectly fine. Our PCO2 is what reflects ventilation, and it's 39, so we're good there. B, do we need to suction and check the airway? No, there's no indication that there's any type of problem with secretions. C, do we need to administer sodium bicarb? Well, our bicarb is only 16, so yes, it may need a bump to try to help with the acidosis that we're seeing with the pH of 7.2. Do we need an echocardiogram, which is option D? We don't have any history mentioned in the question of a cardiac issue. We may call in cardiology after the baby is stabilized better and have them just check and see if there's any congenital heart defects, because we know that echocardiography is the best way to check for a congenital heart defect. So we're not going to do that quite yet. We're in an emergent situation. We've got a baby that it has a pH of 7.2, so we've got to get that corrected. There definitely may be an issue with congenital heart defect, but that's not what we need to worry about right now. We need to administer sodium bicarb and pull them out of this acidosis. The next question, epinephrine and atropine are recommended for the treatment of what condition? Answer A is asystole, B, ventricular fibrillation, C, electromechanical dissociation, D, SVT, supraventricular tachycardia. So the correct answer to that is asystole. We know that epinephrine and atropine both stimulate the heart rate, and epinephrine especially stimulates contraction of the heart. So if there is asystole, that's one of the first groups of medications that we pull from the crash cart is epinephrine and atropine. So that is to treat asystole. The next question, defibrillation is indicated to treat which of the following arrhythmias? This is true across all of the age groups. A, supraventricular tachycardia, B, pulseless VTach, C, premature ventricular contractions, or D, asystole. We know that defibrillation is appropriate for pulseless ventricular tachycardia. We need to use higher voltage for this, and the synchronization on the defibrillator needs to be turned off. The patient should be sedated if possible, and we need to intervene as soon as possible. Pulseless VTach definitely affects the perfusion at the tissue, and we need to correct it before it becomes asystole. At the point of asystole, then we don't need to use that. We need to definitely depend on resuscitation efforts, and we need to depend on our epinephrine and atropine to try to get the heart started back. Okay, well that's a few questions to help with emergency care. Make sure that you subscribe to this channel, and we will have more uploads soon, and some more questions to help prepare you for all 3 exams. Make sure that you join us at RRT and Neonatal Pediatric Specialist Respiratory Therapy Review study group, and we will definitely be reviewing on the wall. We have live games and videos and lots of interesting information to help get you ready for boards. There is tutoring available at your request, so just message me on the inbox. Let me know you're interested. Thanks for listening, and talk to you soon. Have a great day.